Hello, and welcome back to Wellness Wednesday, a monthly series where experts share practical tips and techniques on topics that are important to patients, survivors, and caretakers alike. I'm Arent Krieger from the Ralph Pancreatic Cancer Foundation, and I'm happy to be back moderating tonight's session, where I'll be talking with Dr. Alyssa Vandenberg about pain management and sleep strategies. But before we get to Dr. Vandenberg, I want to make sure you're up to date on all of Ralph's upcoming events. Have you built your NCAA brackets yet? There's still time to join in Ralph's Young Professional Board's March Mania, but time is running out. There's lots of great prizes for the taking, so make sure you click on the link in the chat and get in on the action. The tourney starts tomorrow, so lock in your winners by 11 a.m. Central, and you'll be able to help support Ralph's efforts and mission. And don't forget to save the date for this year's Dash for Detection. Dash will be taking place on Saturday, June 11th in person at Montrose Harbor in Chicago. But don't worry, if you can't make it to Chicago or you're not quite ready to be around people yet, we have virtual options, including our Dash at a Distance, where you can participate anytime in June. And we're really excited to be able to offer both opportunities for our community. So save the date, and more Dash for Detection details will be released soon. So be sure to keep an eye on our social channels. Now, a few housekeeping items. Don't forget to ask questions throughout the session. We do keep them till the end to be able to make sure that we can get to everybody and make sure all our questions are answered. You could do so in the comment section below, or you could send an email to us at info@ralphfoundation.org. Again, we'll save all questions to the end. Now, on to our show. Dr. Alyssa Vandenberg is a clinical health psychologist at Northwestern Medicine and a postdoctoral fellow at the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. Alyssa is also a former member of Ralph's Young Professionals Board. Welcome, Alyssa.
Hi, thanks so much for having me. I'm going to share my slides.
Great, thank you.
All right, happy Wednesday, everyone. Tonight I'm going to be presenting on living with cancer, pain and sleep management strategies. A lot of the examples I'm going to give are for cancer patients and survivors, but these strategies really apply to anyone, caregivers, family, friends alike. So I'm going to give a little background on myself. So I am a clinical health psychologist and postdoctoral fellow. And like Aaron said, I started as a Rolf YPB member almost 10 years ago. I went on to get my PhD in clinical psychology from Duke University. And then I completed my clinical internship or my residency at Yale School of Medicine in behavioral medicine. So I've gotten into this niche of clinical psychology where I'm working at the intersection of health and chronic conditions. And currently I'm completing my postdoctoral fellowship at Northwestern University. My research area is in behavioral interventions for pain in patients with cancer. And I'm doing that through the Robert H. Lurie Comprehensive Cancer Center. And then my clinical experience has been in oncology, sleep medicine, complex gynecology, fertility, sexual medicine and menopause, smoking cessation, and more. And I have nothing to disclose. I receive no industry sponsorship and have no conflicts of interest to report. Information presented today is for educational purposes only and is not intended as a substitute for consultation or treatment with a mental health professional. All right, so to get started, I'm going to give you an overview of pain and sleep issues in the context of cancer and why it matters. So pain and sleep issues are two of the most common symptoms experienced by patients with cancer. In terms of pain, a meta-analysis from 2016, looking at data from 122 studies, found that more than half of patients with cancer had pain. And this especially affects patients with advanced cancer, where we see pain rates of over 66%. In terms of sleep, the National Cancer Institute has reported that as many as half of patients with cancer have problems sleeping. And insomnia is one of the sleep disorders most likely to affect patients with cancer. So I'll be talking more about insomnia, but insomnia refers to trouble falling asleep, trouble staying asleep, difficulty waking, and poor quality sleep. And for those of you who have experienced pain and sleep, it probably doesn't surprise you that these two things can go together. So here's one of the ways that the pain and trouble sleeping can be connected. So after having trouble sleeping, that can increase pain. And sometimes to cope with poor sleep and pain, people might start reducing activities and spending more time in bed, and that can have negative effects on the sleep system and then lead to more trouble falling asleep, staying asleep, waking up too early, poor quality sleep. So what I'm going to be talking about today is what are the non-medication options for helping with pain and sleep. So most approaches that are behavioral are informed by what's called cognitive behavioral therapy. So cognitive behavioral therapy, or what I'll refer to as CBT, typically focuses on two goals. The first goal is educating patients about how thoughts, feelings, and behaviors can contribute to symptoms such as pain and sleep. And then skills training to change patterns of thoughts, feelings, and behaviors to help reduce symptoms and improve day-to-day functioning. There's good evidence for using cognitive behavioral therapy for sleep. Meta-analyses and systematic scientific reviews show benefits of CBT for pain for various pain conditions, including cancer pain. And also good data for CBT for sleep. In fact, the American College of Physicians recommends that adult patients receive CBT for insomnia as a first-line treatment for chronic insomnia, and that's above medication. And besides being evidence-based, CBT can improve symptoms caused by various factors like cancer medications and treatments, and are safe adjunct to medical management. So now what I'm going to do is I'm first going to talk about some of the pain management strategies that we have, and then some of the sleep management strategies. So what the CBT strategies for pain do is can help patients with the thoughts, feelings, and behaviors that accompany pain. So here on my diagram, I give some examples, but thoughts that can come up when you have persistent pain are things like, I worry about whether the pain will end and there's nothing I can do to reduce my pain. Feelings that can come up are fear of pain, anxiety, depression, and some of the behaviors include avoidance of activities, cycling from overactivity to inactivity, and social isolation. So all of these things can be made worse by pain and make pain worse. So to kind of talk about some of the strategies that we might recommend for pain, I'm going to give a case example. So I want you to meet Jane. She's a 59-year-old woman with cancer and persistent pain. Jane can't seem to keep her pain out of her mind and is afraid that it may become worse. And out of fear of exacerbating her pain, Jane has started avoiding physical and social activities. By not engaging in these reinforcing activities, Jane has begun experiencing higher levels of negative mood, physical challenges, and social isolation, which in turn may worsen her pain. So what do we do for Jane? What I typically do with patients and think about is having a menu of pain coping skills or a toolbox of coping skills. And there are lots of different ones available, but I'm going to talk about kind of 4 categories of pain coping skills. And then I'm going to provide 3 examples of those skills and walk through those with you. So the first group of skills are relaxation strategies. So things like progressive muscle relaxation and controlled breathing. distraction techniques like imagery, pleasant activity scheduling, strategies for managing activity like activity pacing, and cognitive strategies. So what to do when you're having pain thoughts come up. And those two strategies that I like to use are cognitive restructuring and cognitive diffusion. So if you are watching from a laptop or a phone or iPad, I might take a screenshot of this slide. It can be a helpful reference for the future. And because I won't be able to get to all of these activities, but you can look up some of these on Google afterward. All right, and I'll move to the next slide. So the first strategy I'm going to talk about is controlled breathing. So there's growing research that paced breathing at a slow, predetermined rate, guided by instructions and cues, can help with pain. There's been research done on controlled and abdominal breathing combined with opioid therapy for pain during chest tube removal after coronary bypass surgery. And controlled and abdominal breathing has also been studied combined with morphine for wound pain for patients during burn care. And for my dissertation at Duke, I tested a controlled breathing intervention for women undergoing MRI-guided breast biopsies to detect for breast cancer to see if that helped with pain. So there's more data coming out about it. And what I'll show you next is an example of a controlled breathing exercise that you can do. So this is one of my favorites. It's called square breathing or 4-square breathing. And basically what it involves is breathing in for 4 seconds, pausing for 4 seconds, breathing out for 4 seconds, and again, pausing or holding for 4 seconds. So I'd like to do a quick tutorial with all of you to demonstrate how this works and how it looks. So we'll start by breathing in for 4. So in, 2, 3, 4, hold, 2, 3, 4, out, 2, 3, 4, hold, 2, 3, 4. And this is something that you can repeat over and over again. I have patients practice this when they're having a pain flare, if they're having persistent pain, but also in settings where they're experiencing acute pain, like during a biopsy. Another thing that you can screenshot and come back to, but it's great, it's free, doesn't require any devices, and is something that you can use in a variety of situations. All right, another pain coping strategy I like to talk about with patients is called activity pacing. So this is for patients who are having more of that persistent pain. When patients with persistent pain try to increase their activity, they often fall into a pattern in which they push themselves, especially on a good day, until the pain becomes so severe. And unfortunately, their pain may become so severe that they have to rest for a long time to recover. And patients may sometimes describe it as, I ended up paying for it, and the pattern repeats itself. So it's this pattern of overactivity, severe pain, prolonged rest. So the best way to avoid the overactivity cycle is to develop what we call an activity rest cycle. So this cycle involves alternating planned periods of activity with regular rest periods. So to do this, I have patients identify activities they tend to overdo, things like cleaning, cooking, and exercising sometimes, and then having patients set a realistic time limit for these activities. And when they reach that time limit, stop, rest, and relax. So instead of waiting for the pain to come to stop the activity, stopping with the time limit and then setting a amount of time that you have to rest. And then we have folks keep track of how many times they use this cycle. The last strategy I wanted to talk about was what to do is the cognitive strategy. So what to do with the pain thoughts. So I put a little diagram here to kind of walk you through this. So, when you're having pain, it's often accompanied by some primary feeling that comes up. So you start having pain and you might feel angry, you might feel afraid, surprised, sad. And then sometimes what can start happening is these thoughts get going, like it's terrible and it's never going to get any better. There's nothing I can do to reduce the intensity of the pain. And that can be kind of followed by like a worry spiral or feelings of guilt, shame, or embarrassment. So what I like to talk about with folks is the couple strategies of the first is called cognitive restructuring. The second one is called cognitive diffusion. So these are strategies to try to do something with the thoughts. So we're potentially preventing or lessening a worry spiral or feelings of guilt, shame, embarrassment. So a couple of the strategies are restructuring, asking yourself, is there another way to look at this? What's the evidence for this? Am I overestimating the likelihood of this happening? Am I underestimating my ability to cope? And thinking like about a thought, it's terrible and it's never going to get any better. It's kind of like Socratically questioning that thought. And then the second strategy is called cognitive diffusion. It comes more out of the mindfulness literature. And what it involves is just labeling a thought that you're having as a thought. So saying to yourself, okay, I'm having the thought that there's nothing I can do to reduce the intensity of the pain. I'm telling myself the story that it's terrible and it's never going to get any better. What the research has shown is that even just labeling something as a thought or a story can provide therapeutic benefit because it makes it feel less like truth or reality or destiny. So the next time you catch yourself having some of these negative thoughts about pain, asking yourself, is there another way to look at this? Or can I tell myself, I'm telling myself the story that there's nothing I can do about the pain. So a couple strategies to try. All right, and now we're going to move to sleep management. So to start off this section, I wanted to talk about some common sleep myths and why they're not helpful. You may have heard this before, but some people will say, I absolutely require 8 hours of sleep to function during the day. And for why it's not true is there's a wide range of sleep needs. The average amount of sleep needed for an adult is unknown, but probably less than 8 hours. And sleep duration is only one of the many determinants of daytime functioning. So what the research is finding is that sleep quality is probably more important than the total amount of sleep. So really trying to help improve that sleep quality is one of the goals, and some of the tips I'll go over talk about how to do that. Another myth is if I spend more time in bed, I'll get more sleep and feel better the next day. What this can do is actually interfere with what's called sleep drive and confuse your biological clock. And in addition, spending more time in bed may actually increase depression. Something else you may have heard is that I'm older, so insomnia is just a fact of life. And while there are increased awakenings from sleep with aging, not all older adults develop insomnia. And there are also things you can do to prevent insomnia as you age, and I'll be going through those tips. And then something else that comes up is that I can't do anything to help my sleep because my insomnia is caused by a chemical imbalance. And there's actually no evidence of this, and sleeping pills don't target a chemical imbalance. And these myths come from a book that I'll be talking about a little later, but the citation's at the bottom of the page. All right, so in terms of what do some of the strategies for sleep management, insomnia management, those target when we're thinking about the behavioral options, is that CBT strategies for insomnia can help with, again, thoughts, feelings, and behaviors that accompany sleep issues. So some thoughts that can come up are ones like, I'm never going to get any sleep, feelings of frustration and anxiety, and certain behaviors that actually get in the way of sleep. So things like lying awake in bed, watching the clock. So now I'll get to some of my tips that you can practice to fall asleep, stay asleep, and get better quality sleep. So the first one, and this is one that's especially important after the time change, is trying to wake up at the same time every day. So for example, 6 a.m. on weekdays and weekends, and getting out of bed soon after your alarm rings to set your body clock. Otherwise, what can happen is you start to develop what's called social jet lag. So symptoms of jet lag without actually going anywhere. If you're really changing your wake up time from like weekdays to weekends. And then the second tip is going to bed when you are sleepy. So sleepy meaning like nodding off. So I like to call it like bobblehead. You can't keep your eyes open, heavy eyes. If you don't feel sleepy at your target bedtime, say it's 10 p.m., wait until you do feel sleepy. So it may sound counterintuitive, but we want you to wait until you really feel like you could fall asleep in order to get in bed. You may feel a little sleep deprived initially, but stick with it. Your body will adjust. And we don't want your bed to be associated with the activity of trying to sleep because it inadvertently interferes with the natural sleep process. So instead, we want bed to just be associated with sleep and not trying or wanting or praying to fall asleep. The third tip is if you can't sleep, stop trying. Get up or sit up and do something relaxing and lay down only when you are sleepy again. When you lie in bed awake, trying to sleep, wanting and hoping to go back to sleep, you're training yourself to be awake in bed. And especially when you start doing this, it might take a few tries. You might be getting out of bed, then getting back into bed, feeling sleepy, but then you realize you're not able to fall asleep, get back out of bed, but eventually your body adjusts. And as best you can, try to use the bed only for sleeping, not watching things like Netflix. If you read, journal, etc. in bed before falling asleep, try sitting up with a propped pillow to do so. But really the most important activity to eliminate from the bed is the activity of trying to sleep. That's when we want you to get out of bed, wait till you're sleepy to get back in bed. And this depends on, let's say, if you're how things are going with your treatment, but we often will recommend avoiding daytime napping, which can interfere with what's called sleep drive. As you go through the day, you accumulate what's called sleep drive, deep sleep drive. And ideally, by the time you go to sleep, you've got a lot of sleep drive. But what can happen when you nap is that you lose some of that sleep drive. So then maybe by nighttime, you don't have as much to get you to sleep and keep you asleep. So obviously, if you're undergoing certain treatments or whatever's going on in your life, you may need to nap. But it's something to consider avoiding or limiting. Another recommendation is, making sure your devices have night shift mode turned on. And if you can set an electronic curfew for 30 to 60 minutes before your target bedtime. Blue light from electronics can disturb sleep. We used to think this was more of an issue with teens only, but we're finding that blue light can impact adults as well in their sleep patterns. All right, so next steps. So how do you access, outside of my slides, some of this CBT for pain and sleep materials? So first, your hospital may have referrals for CBT therapists. We at Northwestern do, and in the Lurie Cancer Center. The Association for Behavioral and Cognitive Therapies also has a function where you can find a therapist on abct.org. And then the American Psychological Association has a psychologist locator on their website. And then these are two books that I like to recommend to patients. The first one is called The Pain Survival Guide, How to Reclaim Your Life. It's by Dennis Turk, who is a bigwig pain psychologist. And it's a great book. And then the other book is called Quiet Your Mind and Get to Sleep, Solutions to Insomnia for Those with Depression, Anxiety, or Chronic Pain. And that is by Colleen Carney, who was a colleague of one of my supervisors at Duke's Sleep Clinic. And she's now a sleep psychologist in Canada. And this book's excellent. So highly recommend. And that's it. So thank you.
Thank you, Dr. Vandenberg. That was really helpful. We've gotten a lot of questions that have come in, so we'll get started with those. If you have additional questions, anybody who's watching, go ahead and put them in the chat. If you don't feel comfortable doing that, it's okay. You could send it to us at info@ralphfoundation.org. Okay, so one question we had was, can you walk us through what a CBT session looks like? I think it's something that we hear all the time, but what is it actually? And obviously you can do an expedited version of it.
Oh, sure. That's a great question. So typically at the beginning of a session, it's more structured than some other types of talk therapy. But I'll do some kind of check-in. So if I'm doing CBT for pain, I'm checking in on, how was your pain in the past week? I often have patients track their pain in some sort of way. And so we review, what happened when did you have more severe pain? What happened on those days? And then what we do is, start to think together about, were there any thoughts that came up? Were there any behaviors that came up, feelings that came up that seemed to exacerbate the pain, make things worse, or make things better? And then often after that, I'll typically review, one of the pain coping skills. And then I do kind of one skill per session.
Okay.
For CBT for sleep, it's sort of similar in the beginning, a check-in. I often have patients keep sleep diaries. We'll review their sleep for the week and see, if any issues arose, where those arose, and then kind of focus on a CBT for insomnia skill for that session. And then we make goals for the following week in both the CBT for pain and CBT for insomnia.
Thank you for that. So I'm going to jump back and forth between pain and sleep. So bear with me. One question that just came in was, what are some strategies as a cancer survivor to deal with your healthcare providers telling you your pain's all in your head?
That's a great question. So I actually have in another presentation about the services I do at Northwestern. I have a slide that says, my provider, my physician just referred me to a pain psychologist. Does that mean the pain's in my head? And I would say, no. I'd say pain is pain. What I think of my role as a pain psychologist is to see, you know, are there ways that we can help you cope with the pain? So are there, you know, the thoughts, behaviors, or feelings that are potentially exacerbating the pain? Not to say that those things are causing it, but are they, you know, potentially making things worse? And are there ways that we can intervene? So all that to say, I hear that so often from patients that, you know, who get worried about meeting with me, thinking that I'm going to suggest that their pain is in their head. But really I'm thinking about, you know, are there thoughts, behaviors, feelings that we can work with to potentially help lessen some of the pain? And also, you know, another thing I like to focus on with patients is, how do we help you still live the life you want to live in spite of the pain? And, you know, pain can really rob you of certain joys in life. And how do we get more of those kind of back in your day-to-day?
Sure. Is there anything specific that you would recommend that they say to their doctor at that moment?
Oh, that's a great question. Part of me wants to say no, right. But I think, you know, saying that, I think two parts. One, you know, saying, are there any other medical management options I should be looking at because I am having this pain? And two, you know, asking if it feels applicable, you know, for referral to somebody like a pain psychologist who can help. I also work closely with pelvic floor physical therapists. You know, I think asking for referrals to, you know, another type of provider like me, like physical therapy, who could also provide help.
That's great. I think, you know, having an added layer of stress on an already stressful situation, to have somebody questioning that's awful. So I really appreciate your insights on that. Our next question says, a friend told me to take a walk after dinner to help with my sleep. She swears this will help. What do you think?
That's a great question. So it could potentially, the way in which it could potentially help is that it's the more time you spend out of the bed on your feet, you do accumulate more of that kind of deep sleep drive. So if you are, you know, say, doing more physical activity during the day, you're more likely to accumulate more of that deep sleep drive. And so ideally, you know, by the time you get to bed, you're releasing that, and you're, say, up here, and if you've got a lot and it's enough to get you to sleep and keep you asleep. But, you know, I'm not sure how much, you know, a walk after dinner might, you know, maybe your deep sleep drive would have been here and the walk will increase it to here. So I think, you know, the strategies that I think are ones that can move the needle a little more are things like, you know, having a consistent wake up time, waiting until you are sleepy to go to bed. So like, bed does not open until you are having like bobblehead or heavy eyes and it feels like you can't stay awake. And then the third one being that you are, you know, reserving bed as a as the place where you sleep. It's not where you're doing other things. It's not where you're worrying, hoping, praying to fall asleep, but that's a sanctuary for sleep only. So I think those things will give you a little more bang for your buck.
Okay. Now I'm going to branch off on that front. The worrying, praying, you know, some people, myself included, need to watch something to go to bed. It's like this distraction. I don't have to think of anything. What do you say for that? And, I imagine for those experiencing pain of having something that kind of distracts them from thinking about it, can it be helpful at times?
Yeah, I think as long as you, I think there's some variability. Like if you are having an okay time falling asleep, then, I often say we can loosen some of these rules or guidelines. But if you are having trouble falling asleep, what I would say, something like I've had patients be like, don't take away my book from me in bed or don't take away my Netflix from me. So what I would just say is, if we can have you kind of propped up and sitting, just so you're in a kind of different position doing that than sleeping. So I would say, if you want to watch Netflix before bed, I would just kind of prop yourself up. So we're just like associating being horizontal in the bed with sleep only.
So we should take away the sleep timer is what I'm hearing. Okay, how about our next one? My mom has stage 4 cancer with metastasis in 3 spots. What can we expect to help with pain?
That's a great question. I think, and as I said at the beginning of the presentation, that we do know that patients who have advanced cancer tend to have more pain. So I think one is making sure that it's medically managed. Meeting with palliative care teams is one thing I would recommend. And then I think, also thinking about some of these CBT for pain skills, things like, doing some of the controlled breathing when you're having especially bad pain, listening to one of the relaxation strategies is called progressive muscle relaxation. And that would be something you can look up on YouTube and find some examples where you either go from head to toes or toes to head, tensing and releasing different muscle groups. And the idea is that you're training your body to notice the difference between tension and relaxation. And that can be, is one of the pain coping skills. I often like to use with cancer patients, I've worked with pleasant imagery. So that would be another thing I would look up on YouTube if there are any pleasant imagery recordings. And then I think things like, the activity pacing. So say your mom is having a better day and it's like, I want to clean the house, recommending to her that she set, a time limit for how long she does an activity, and then make sure she also sets time right after that for rest. And then, seeing if she is having, some of these thoughts come up about her pain that are, more catastrophic, and kind of talking to her about, if there are ways that would be helpful for her to manage those thoughts. So, using that strategy like cognitive diffusion, where you're saying, okay, I'm having the thought that there's nothing I can do for them. So that's what I would be recommend is both, make sure it's medically managed, meeting with palliative care, and also seeing if some of these CBT for pain strategies are helpful.
Okay. How about the apps, whether it's Calm or Headspace or, any of those? Are those meditation? Do you recommend doing that as part of helping with both the pain and the sleep aspect of things?
Yes, there's increasingly more data about using mindfulness-based strategies for pain. So I often recommend that patients incorporate some of that as we're working on some of the CBT for pain strategies. So Calm, Headspace are great. Headspace, I know, does have, if you search on the Headspace app for pain, they have specific, meditations that are geared toward pain. Mm-hmm. And then in terms of sleep, I think, do what's helpful for you. I think it can be a nice kind of wind down routine to do something like one of the sleep meditations in Calm or Headspace. But I think it is also important for sleep to do those kind of 3 things I talked about with consistent bed or consistent rise time from weekdays to weekends, using bed for sleep, or using horizontal position in bed for sleep. And then the last one being waiting until you are sleepy to go to bed and not getting into bed, before you're start having some of those sleepy cues.
Sure. Okay. How about what do you advise for if you're having trouble sleeping, but you share a bed with another person? They're saying, I don't want to sleep away from my partner, but I feel like I'm keeping both of us awake and it makes it harder for her to go to sleep. So what about that?
That is a great question. So I have seen patients who, I think it's going based on what's important to you. And if it is really important to share a bed, what I recommend is, if you're having that trouble sleeping, I would, get out of bed, maybe go to another room that it's somewhere comfy, cozy, that you're able to do a, kind of relaxing activity, waiting until you're having some of those sleepy cues, heavy eyes, bobblehead, to get back in bed, see if you fall asleep. And again, when you're starting that process, it might take a few times, but I would say, sticking with those 3 strategies to see if that helps improve sleep. So it's not as it's not interrupting things as much with your partner.
Sure. Now, how about if somebody's in pain and they can't fall asleep? The idea of getting up out of bed and going someplace and then getting back into bed, and will all the up and down affect the pain? Would it make it worse?
That's a great question. I think if, depending on how severe pain is, if it feels like it's going to be too much to, and depending on what you're going through, let's say through cancer treatment, if it's going to be too much to get in and out of bed, I would just, kind of do the propping yourself up and then waiting until feeling sleepy to go back horizontal. That's the CBT for insomnia skills have even been used in prisons where inmates are restricted to their bunk. And so what they'll have them do is kind of, if they're in their bed, sitting up until sleep and then laying back down, or, sitting on a different side of the bed during wake hours, and then but reserving that laying down horizontal for sleep. So I think if it's too much to get in and out of bed, I would just suggest, sitting up, propping yourself up, and then kind of waiting until feeling the sleepy cues to lay back down.
Okay. And would that include turning on lights and going all out with it? Or is it okay as long as you're sitting up, if it's still dark and you're watching something? Or
I would say you don't need to. I'd keep things like still kind of in sleep state mode where, it's quiet, lights are off. If you're doing an activity, have it be something kind of relaxing or enjoyable. But I think the most important thing is if we can get you out of bed, but if not, then just sitting up in bed.
Okay. How about tips for caretakers who are feeling anxious and worried about their loved one and they're having trouble sleeping? What would you recommend for them?
That's a great question. I've been a caregiver myself, and it is really hard. I think the thing I most recommend for sleep while you're a caregiver is your brain is going to be busy. So what I want to do is try to get busy brain out of bed, or busy brain propped up in bed. So, using that strategy of, if it feels like your mind is just going, getting out of bed, doing something relaxing, or propping yourself up and waiting until you are feeling so, you're having those sleepy cues. You're like, I can't keep my eyes open. I'm going to lay back down. Sometimes, we even work with patients who have insomnia. We might do things like kind of time in bed restriction. So if it feels really hard to, not have that busy brain in bed saying, okay, we're only going to have bed open from midnight to, let's say, 6 a.m. and you have to wait until midnight, which may feel like eternity, to get into bed, and then waking up at 6 a.m. So we sleep deprive you a little bit, and then gradually add time back. So that's, another thing to kind of think about is if it feels like, we can't get kind of the brain to settle down, kind of pushing back your bedtime until it's like, feels like you cannot keep your eyes open. And that's when you're getting into bed, and then, setting a consistent wake up time.
Okay. Going off of that a little bit, another question is, this might be a naive question, they say, but is it possible to sleep in a bit on a day off without it being detrimental to your overall sleep cycle? Or is it better to aim to just maintain that cycle?
That's a great question. What I would say is either, if you need to sleep in, doing like, kind of extending 1 or 2 hours max on your wake up time if you can. But yeah, we're just trying to think about it. I think about it like time zones, like going more than 2 time zones you might start having some kind of jet laggy symptoms. So I would say, sleeping in another hour or 2 is, that would kind of be the goal I would think about.
Okay. As a caregiver, how can I support my loved one when they aren't sleeping well? Oftentimes the patient won't try new ideas to better their sleep. So it seems like a cycle. Do you have specific ideas on where somebody could start to give them better help to get them to have better sleep?
Yeah, that's a great question. I think, one, taking care of yourself as a caregiver and making sure that you are getting your needs met and getting sleep, and, doing some of these strategies if you're having trouble sleeping is important. And then I think, kind of gentle suggestions. I think the book, I'll go back to that slide, but the Quiet Your Mind and Get to Sleep, could be something to kind of introduce or, show some pages from. But I think, it's really hard as a caregiver, and, but I think, one, meeting your needs, and 2, kind of gentle suggestions and seeing how that lands, and, knowing that you're doing the best you can.
Sure. How about caretakers helping out with the pain management aspect of things? When their loved one is, for lack of better phrasing, spiraling, that they're in so much pain, it's not going to end. How can caretakers kind of stop that process and guide them in the right direction?
I think what I would say, and I'll go back to this slide, is validating the feeling that they're having, telling, the patient, like, I hear how, frustrated or angry or, anxious or sad you must be. And then it's hard to do some of the cognitive work on a loved one. So I think if you can kind of redirect them, think about I'll go back to this kind of menu, suggesting something like, what if we watch something distracting? What if we, listen to something together, did an imagery exercise together, suggesting like doing a relaxation exercise together, like progressive muscle relaxation, controlled breathing, and seeing if, I think helping them relax, get distracted, if that can kind of help. But it can be hard to, I think some of these cognitive strategies, it's one thing to do on yourself and it's another thing to do on a loved one. So I think, thinking about, or, doing like a pleasurable activity together. So thinking about something relaxing, distracting, pleasurable, and validating the feeling.
I think the validating part is really key, because people want to feel as though they're being heard and understood, and sometimes the need for that over an answer or over help. I think that there's a huge aspect of that as well. Okay, I think we have one more question before we go to my favorite ending question of your key takeaways. So this person said, I'm not sure if this is in your wheelhouse, but do you have any advice on how to communicate the need for a rest pattern to loved ones if you're battling a chronic illness? So I think what they're saying is, when they're having their own challenges and they're being a caretaker to somebody who's having challenges, and the need for sleep and rest is there for both of them.
Yeah, that's a great question. I know when Roz presented, she talked about boundaries. I think boundaries is the important thing to think about here is setting, some boundaries for yourself. Because, I like to think about, and Roz may have used this example, but, putting your mask on the airplane, your oxygen mask on the airplane on, doing that first, because you're not going to be any use to the person you're caregiving for if you're not taking care of your own needs. So that's one thought I'm having. And then, I think that would be, and then also thinking about, is there any other help that you can bring in, and whether it is setting up something like a carrying bridge or a meal train to get other people to chip in and take some of the load off of you, or whether it's, bringing in home health to, I think, kind of rally the troops. So it's not all on your shoulders. And, but I definitely, think about putting your oxygen mask on first. And, knowing that in order to be helpful, you have to be taking care of your needs and setting good boundaries and getting help.
For sure. There's no shame in asking for that help, for sure. So something we ask all of our presenters is, what are the 3 top takeaways you want our audience to leave with tonight?
Great question. So I have a slide with this.
I love that you came prepared.
Takeaways that I wanted to touch on were that, that pain and sleep are issues that are really important in the context of cancer, and half of patients with cancer may experience pain and have problems sleeping. And that CBT for pain and insomnia can improve symptoms caused by a variety of factors, whether it's changes in treatment or stressors in life. So whatever the reason that you are having the pain, having the sleep issues, that these tips can help, and they're safe adjuncts to medical management. And that the third takeaway is that, ways to access CBT for pain and sleep include, finding a CBT therapist, and also, referencing a couple of these books I talked about, Pain Survival Guide and Quiet Your Mind and Get to Sleep. Yeah.
Great. Thank you so much. If you want to put the slide back up of how people can get in touch with you. Yeah. Again, everyone, we will be putting this in, we'll be sending this out, and it'll be up on our website. So you don't have to rush to grab it right now. But Dr. Denburg, thank you so much for sharing real important, insightful information tonight and practical tips that people can actually walk away with and do things to make themselves feel better or their loved ones better. So we're really appreciative to have you with us, and for your previous service on the board.
Thank you. Thanks so much for having me.
Take good care. And thank you everyone for joining us and sharing your questions tonight. If you're catching us on the replay, be sure to write replay in the comments when you ask your questions. That way we can be sure to get them to Dr. Denburg and get back to you with that. Next month, we'll be coming on Wednesday, April 20th, where I'll be talking with Christine Rozandich, who's a nutrition educator and health coach from Cancer Support Center. And she's back with us talking about the Cancer Fighting Diet, Part 2. So keep an eye out for details on that. And if you have other ideas on topics or speakers for future Wellness Wednesdays, please send them to us at info@ralphfoundation.org. Don't forget, brackets, join in. I don't know if anybody's old school like me and writes them out like this first, but again, March Mania will kick off officially tomorrow. 11 a.m. is when the buzzer will go off so that you can join us. Lots of great prizes that you'll want to see there. And on behalf of everyone at the Ralph Pancreatic Cancer Foundation, we truly appreciate you joining us tonight and in all our activities. And until next time, we hope you stay healthy and take good care. Good night.